start synthesizing. So some of this stuff might look like applied and being recorded. So today is April 7th. It's almost noon here in California. Thank you all, and for those later joining or viewing this later. Um, this is a series I did a while ago. Someone sent me this old school anatomy book from Leipzig, um, Werner Spalteholt's Handbook of Anatomy, and I thought it'd be fun to draw over top their images and then, start synthesizing. So some of this stuff might look like applied kinesiology, and some of it's my own discoveries, and nothing really new except just starting to bring it all together, right? So that you can start to roadmap of like, I don't understand why, I fixed this person's psoas, but stuff keeps coming back, right? And so I have the lovely honor to introduce Dr. Asya Thea Stefa Devak Patel, as threatened, if you can remember that by the end of the course today and get all those names correct, some sort of bonus prize for you. Asya is a doctor of physical therapy from University of Miami. She lives and resides currently in the Rat's Mouth. That's Boca Raton, which sounds so much sexier than calling it the Rat's Mouth of Florida. I call her a recovering physical therapist because, she was just not happy with me.
A recovering physical
Still,
therapist.
still, okay, currently. Um, seeking to find more ways and such to do that. Her and I met through neurokinetic therapy and come from completely different backgrounds, but end up at the same page and love it. We don't always agree, but that's also fun to that as well. Um, and she's absolutely brilliant and here to guide us today as well. So thank you, Asya, for joining us.
Thanks so much for having me, including me. Obviously, you guys all know Jordan. Probably taken one or all of his courses in the past at some point. I find it really interesting that we've come to basically the same point as far as viewing the human body, of course, with our relative differences. But my background as a physical therapist contrasts greatly from his background, primarily from architecture, buildings, and then applying that to the human body from the original lens of massage, but obviously has taken that way, way farther. Cranials, polarity, Chinese medicine, just his own studies and curiosity, and obviously the creation of adaptable polarity and his own way of exploring and teaching about the body. So it is my honor to be able to listen to and contribute to everything that we're going to chat about today.
Thank you so much. That being said, let's dive in. So what do I do again? I push this button down here and then I go like that, and then you all now see that. Let me turn that off really quickly too. Yep. Um, right. So, as you can see here in the background, um, some old school images, really cool, and then just kind of came in and highlighted and did some stuff on there. Um, Up on the top, kind of, myoskeletal, you see the stuff circled from 2 years ago. And each of these little different segments on each is done and repeated, and then even given then in the notes a little bit. But we're going to expand upon them and not sit here and read off of slides and have a bit more fun than that. Um, so the first thing is pronunciation. How do you say that? Asa?
Iliopsis.
There it
Um,
is.
these are ancient dinosaur names.
Iliopsoas. It is two muscles, and then they join in and both grab the lesser trochanter down in here. And so again, they don't actually join and become one ever. They just grab the lesser trochanter together.
Two separate muscle fibers, they have the same attachment point. And so, because they seem to have similar actions, whoever was in charge of naming things back in the day Um, Obviously named them separately, psoas, iliacus, and then came up with a larger grouping for it, iliopsoas.
Okay, so if I could time travel, I've now figured out what I would do. I would go back and change anatomy and make it simple instead of
It
this
is
dumb shit
simple.
that
It's
we
not
have to learn and study in another language.
okay. Well, that's a different topic for another day.
So ellipsoas, iliopsoas is two muscles of iliacus and psoas, and they are the classic hip flexors, right? So there's our movement there, hip flexion. Uh, if you ever look at this muscle from the side, like either if you get the 3D experience of doing a cadaver, or if you look at like this image is traced from a do the zoom, do the move from an anatomy app. Um, Iliac is less so, but both of them still super wild, coming from posterior. So right, like so as attaches to the spine, and then comes down, forming part of the pelvic bowl, the lateral and superior pelvic bowl, and then over the pubic bone, under the inguinal, and then back down and under to grab onto the lesser trochanter. Um, it's wild and weird to me.
Have you?
Uh,
You've never dissected, have you?
no, I have not. I want to.
It's
I don't
fun.
know if I can handle the formaldehyde smell though.
You get over it after a while.
Okay. Yeah, maybe I'm due for that. Instead of digitally dissecting, let's go get dirty. And then this weird thing here, we looked that up. Do you remember the percentage?
Of people that I think like 65% of people have a psoas minor.
Oh, it has minor. And that actually attaches to pubic bone and doesn't span the bulk. Is that correct?
Yeah.
Is it becoming vestigial? What do you think?
Probably, although I think it will still be a while before we get rid of it completely. I think there are other muscles that have a better chance of becoming vestigial, like palmaris longus. Um,
Hmm. And fibularis tertius or something?
I know. I actually think that one's more
Hmm.
needed, maybe less on the
I
outer.
mean, we need pinky toes to find where coffee tables are, apparently.
Exactly, it's their echolocation.
Let's finish up on some of the physiology of this muscle. Iliac is attaching to the inside of the ilium. Pretty simple spans. It's a fanned out muscle. And then psoas, it goes all the way up and attaches, even fibers blend into the diaphragm
A little bit.
a little bit. And then we were talking about the spanning of joints. Um, right?
Yeah, I think just as like a general, really giant asterisk, hip flexors get a lot of flack these days. Everybody seems to think hip flexors are to blame for everything to do with sitting. I actually spoke with a new client last week who proceeded to inform me that every step that she takes after standing from sitting and she starts bending forward, she's like, it's just my psoas, just pulling me down. And I'm like, no, no, that's not.
No,
It's
it's
a
gravity.
lot of it's a lot of other things, but um, we tend to see things from a concentric perspective, which really means okay, we understand the action of a muscle, and then we assume that that's the action that the muscle always does all the time in all planes and all situations. So everybody's out to get the psoas. I'm always shocked if people even know that the iliacus exists. So there's just a lot of misunderstanding around how to place blame, if we want to talk about it that way. And just a lot of misunderstanding again of what these muscles are really designed to do. And so big differences between psoas and iliacus as far as function. All
That's
right,
such
let's see
a
if we can keep
big
count.
word.
Times my
Designed to do. Sorry, go ahead.
Oh, I was just gonna say, along with my names, we can count how many times my cat wants in and out.
Oh. Well, while he does that, I'll go over that iliacus. It only spans the hip joint, right? So it is inside. If we look here at the image, Right behind here is the SI joint. It does not span that because it is inside of the or lateral to the sacrum, so it doesn't span the SI joint. It just spans the hip. So that's one job, right? We've talked about this, or perhaps some of you have heard about this of like you only have one joint, you have one job, and you're managing that one joint. Whereas psoas, if we every joint of the low back and the spine, and then the SI, and then the hip, it's arguably 7 to 9, right? Especially if someone has that extra lumbar vertebra. I actually had one of those clients last year. She told me about it, and I was like, "Oh, can I feel and count?" And I was like, "Oh my God, there are 6. That is cool."
Oh.
But it actually left her with a lack of stability. She probably wanted her psoas released, and I said no. Yeah, and so that's a lot of different management. And what you were talking about, like, and how we're taught anatomy, a lot of anatomy in our original anatomy, in my opinion, is cadaver concentric anatomy. And they
Yeah, it's
don't,
carpentry-esque. It's like, oh, well, this is where it starts, this is where it ends, this is how it contracts, this is what it does. That's it.
and that is a simple way to start getting there, right? Like Henry, I'm teaching you all like know where your bones are. And then if you know where the bones are and what attaches to where, and you trace it, and you just know that it pulls there to there, that's the simple side of things. Again, I still don't even understand concentric and eccentric unless I break it down with that con means with and eccentric means against, and then I'm like, oh, okay, right, I got it again. Uh,
Another way to think about concentric and eccentric is concentric is, and well, there's another aspect to it. There's open chain and closed chain, which we can get into if you want. But a simple way to think of concentric and eccentric is the muscle getting shorter or is the muscle getting longer? It doesn't mean the muscle isn't doing work. The muscle can do work in both directions, but if it's getting shorter while it's doing work, it's concentric. If it's getting longer while it's doing work, it's eccentric. And then that whole paradigm is based on understanding, what's fixed and what's not fixed. So open chain and closed chain.
yep, yep. And so most of the time I would be thinking about uh so as is going to be closed chain, right? So if I'm sitting, it's closed chain with my butt. And if I'm standing and walking, it's closed chain through the feet.
Well, that's the other thing is from the action that, especially the image in the top right of this page, the movement with that arrow, that is an open chain movement. So that's really how the average person, even the average therapist, in my opinion, thinks about the psoas. Go ahead, Jen.
Do we have someone?
Jen, did you have a question?
Sorry about that. Okay, I'm good.
Okay. Yeah, feel free to raise a hand, put a question in the chat. I'm currently looking at Jordan's shared screen, so I don't necessarily see when somebody wants to speak. But if you want to jump in and have a
Yeah,
question,
I
feel
think
free to
that,
interrupt.
yeah, that too. I'm all for that as well.
But
But
yeah,
your screen, the chat kind of goes away, huh?
I can periodically check on that. Then we don't have anything right now. But yeah, so this is where, especially as we kind of start the process of synthesizing human movement, to invite yourself to see what your current paradigm is. Like, are you currently operating from the perspective of open chain concentric movement, which is what's taught anatomically, right? That's how I was taught in PT school as well. And I had to add to that. I mean, we, had some in-depth versions of these things, but, even beyond traditional schoolings, to have a better grasp of the human body, it's like, okay, what are all the things the human body should be capable of doing in all settings? And it's a big mind shift. But yeah, try not to blame the psoas until you know you have to blame the psoas. It's more likely that you can blame iliacus.
It's true. And I want to get to that when we start blaming, because then we'll go to the pain referral. But I do want to talk about the movement and the open chain. I actually wrote to the major anatomy apps because they are all very PT doctor based when you look at who does them and everything. And they're all open chain. And I was like, please, please, like, can we do closed chain? Can we help? And they just they wrote back and like ignored it totally and were like, ah, no. And I was like, "Ah, okay, whatever. Guess I'm gonna have to go do it myself." Um, yeah, so the pain pattern, um, a very distinct one. Let's see if I can zoom in a bit more here. Uh,
But it,
where? There we go. But now I can't like get over to that side without. There we go. Can you all see that?
yeah.
There we go. This triangle, that's why I put it there, is a very distinct pattern that people will draw in their bat. They'll like kind of draw the crest and then shoot to the thoracolumbar junction and down the spine. And it's something I've seen time and time again. And so that's why I think whether you believe in the unicorns of trigger points or not, I don't care. The pain patterns are real and people will come in and they will draw it. Now, when they do that, I don't think, oh, all right, great, I'm going to go smash some trigger points in psoas. But I just know that that's the, target muscle that I'm looking at and involved in. And the other pain pattern here is basically like femoral triangle pain and discomfort, right? And so if you think about iliopsoas goes underneath the inguinal ligament as well as the femoral neurovascular supply. So yeah, if you get lack of movement and blood flow through there and get, collagen bonding or adhesions, another unicorn to discuss, then that can cause some anterior hip discomfort. Honestly, if you take over as to kind of some stuff of like agonist, antagonist, and issues that we see that would cause the
I was
mythical
actually
points to
about to
form.
ask you in
Oh,
your practice, because I'm trying to think in my practice, how often when people come in and draw that triangle, do you actually end up having to release the psoas?
um, I can't think of one. I can I can think of opening up that anterior hip that it just feels, I call it glommy or gluey or dehydrated. And then like the iliopsoas don't feel like they're gliding there at the lesser trochanter, and then pectineus is close and all that stuff. I can think of that. But actually,
Yeah, yeah.
anytime digging into their gut anymore, very, very rare. I think often, that's some of the argument as well now is that you're not actually getting to psoas. Although I do feel we can palpate it, right? Like Henry was in recent course, and we get in there and you flex the hip and something pops out. And
Yeah. Well, so we're also kind of talking just to kind of delineate for everybody a little bit. We're talking about two different concepts almost. So when I say like, do you find that that pain pattern, results in needing to actually release the psoas, and then you're talking about, well, there's opening up the hip. So releasing the psoas, the way I'm talking about it is really from a neurological standpoint, is like, is the psoas really the problem, like from the brain's perspective, versus, oh, things are just stuck. The fascia hasn't moved well in a long time. It's not really well hydrated. And so, you can kind of manually go and start changing the environment there, but that doesn't necessarily equate to, well, I'm releasing stuff so that the brain can think about the body differently. It's just like I'm returning all the structures to baseline. Not necessarily how the body chooses to use said structures, but the capacity for the structures to operate independently because they're not stuck together anymore. Like that's, these are slightly different concepts, and a really good thing to start getting a grasp on, like what it is you're actually doing to the body to create the change that you're looking for. And so when structures don't move well and glide, or not well hydrated, as Jordan was just saying, you start getting actual fibrosis, adhesions, things that are more structural in nature. That is its own kind of set of, okay, well, I need to make a change here before you can start changing things on a like neurological level. Anybody who's taken NKT who's showing up here today understands what I'm talking about. If you're
say
curious
what
about that,
NKT is because they might not know the abbreviation, please.
sorry, NKT is neurokinetic therapy. Again, that's where Jordan mentioned it earlier. It's where he and I met. But anyway, different concepts, very, very adjacent, but important to know and recognize when each is needed to be addressed. Jordan, you were just asking if you're going to talk about implications of sympathetic nervous system is a real bugger. Yeah, that's a very general statement. That is correct. Thanks, Dana. Implications of when these things don't move. Is that what you're asking?
Uh, yeah. Well, I just wanted to add, I know no other muscle that has had release parties.
Oh, fair. Yes. I mean, I remember back in my clinic days, a while ago, it would be like, when therapists finally start working on each other, because let's be honest, we're the worst patients too. It'd be like it's like a prep. It's like, you ready for this? I'm gonna get my fingers like knuckle deep into your belly to try to get to your psoas, and it would be like a whole endeavor. A big thing I think to recognize, again, going back to the thought of what are these muscles designed to do, and while they're kind of lumped together as one muscle, iliopsoas, they have very different functions, in my opinion. I say in my opinion because there's still so many versions of this, but like iliacus is very much hip flexor. It has one job, one joint, and it flexes the hip. So I get into that one, relatively often compared to the psoas.
It's pretty
But
easy to get into in comparison, right?
yeah, it just kind of hook around the iliac crest and ASIS. But psoas, every now and then I need to get into it, and I usually find that I need to get into it because there's some sort of emotional component, not because the
Mm.
muscle itself is like really needing physical release work. And then this is where we could postulate that you can't actually get to it physically because you got to move organs around, which I've heard people talk about. But the implications of releasing something, especially like the psoas, not the iliacus, but the psoas, is destabilizing someone.
This is big.
Because, huh?
I was just highlighting that this is big.
Oh, yeah, really, 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 really big. Understand that the body is doing what it's doing on purpose for a reason, even if you don't understand what it is in that moment. And so going and taking away a strategy without understanding what it's providing for the body, especially something like the psoas, where we're talking about lumbar vertebrae, lower thoracic vertebrae, and potentially the diaphragm, there's a lot there that the body's probably relying on. And so big triangle of pain for if that muscle is like, struggling, again, not because it's the problem, but maybe because it's trying to be the solution. Or, it's just not playing nice with the muscles it should be playing nice with, which is usually either the other psoas or potentially the QL, or, the deep abs. So be really careful. If you don't have a way to figure out if the psoas really needs to be released, definitely something to look into, because destabilizing someone through their lumbar area is like never a good thing.
No, it's not. Uh, my first movement mentor mentioned, and it has always stuck, that the psoas, in terms of meat, if you're meat eaters, is the filet mignon.
Yes, I love that.
It's the most tender cut. So you're gonna go in there and, like, excuse my French, fuck with the, in the body, that connection, and miracle stuff just happens. Um, so yeah, it is through the guts, and as you were mentioning, is a nice little segue into the next components. Um, the emotional connection there, right? Like so, it's your soul as, was that what you were joking earlier?
Oh, you took my joke.
No, well, yeah, I didn't
Yep.
say it right. Did I
I
say it
even
right?
told him not to. And it's fine. It's fine. It's fine.
Everything's fine. Uh,
Uh,
this
yeah.
muscle's been referred to as the muscle of your soul. Yeah, muscle of your soul, right? Sorry.
Yes, because obviously, back in the day when I actually did release psoriasis for no good reason, I would joke with my clients who were screaming and painting like, I'm touching your soul right now," and then they would find it funny enough to let me keep going. So, so
And so I have this book that's called Body Encyclopedia, and it has like all these psychological and emotional connections to it, and it references that the iliopsoas is for centering and experiencing one's own center and connectedness. So that kind of makes sense, right? The emotional body is forever interconnected to your physical body, and so there's going to be a component to that. Uh,
ooh. Also, speaking of connectedness, psoas is the only muscle that connects the trunk to the legs, bypassing any attachments at the pelvis.
yes. That's that weird span thing. Um, in classic anatomy trains, the fascial connections, the iliopsoas is considered to be part of the deep front line of fascia. Uh, in a previous series that I have done, I was starting to break down the myofascial lines in relationship to the energetic Chinese medicine lines. And so when the sinew, I use that word because looking at the muscle in terms of relationship so that we're cross-referencing both its physiological location in fascia. So that's the deep front line of fascia. And I'll go into the derivations of that in a minute. Um, and then its relationship so that you can start cross-referencing to the kidney meridian, right? So it is considered related to the kidneys, which kind of makes sense uh, as the kidneys are basically back to back with the top of the psoas. What else would be in between there? A little bit of fascia, right? Like the peritoneum, not the perineum. Um,
Yes.
and so what I think, and the adrenals, of course. Yep.
Adrenal sit on top of the kidney stain.
Um, so been discussing this and think honing in. So in applied kinesiology, Dr. George Goodhart, brilliant synthesizer, um, taking from all different things, and a lot of the manual muscle testing that you see these days are just offshoots of like footnotes of AK, and then people have like muscle activation technique is literally Dr. George Goodhart's first AK find was or origin and insertion technique, right? Let's keep it simple to start. Like you got a weak muscle, um, go to the origin and insertion. So there's this classic story of a serratus anterior being weak. This guy needed to do, I don't know, 100 push-ups or something for a job for lifting or maybe military. I can't remember that context, but he needed to do push-ups and he couldn't. And Dr. George Goodhart came in. He's like, "Oh, you're serrati are weak. Serratus is weak." And he did origin and insertion technique. And then boom, the guy was able to bust out his push-ups. So that ended up becoming muscle activation technique. Squirreling back, Dr. Goodhart got his hands on a manual of acupuncture and found alarm points. And from what I've read, he would overstimulate the alarm points. So he would tonify them and he would notice uh, relationships to muscles. And so in this case, when I'm saying the related meridian, sorry, is kidney, that is that movement and those muscles, just basically hip flexion, um, have a relationship to the kidney organ. And the alarm points are similar of recognizing something to the organ. So I then took, because I'm slightly polarity fixated, right there in the title and logo, I took magnets with a north node and a south node. I still can't remember exactly because one tonifies and one sedates, right? So if you put the magnet over an alarm point, the related muscles on a positive or a negative will either lock or inhibit. Um, and so that's wild, right? And so the alarm points are kind of identification zones on the torso. Most of them are on the central meridian, but few have their own like lungs, liver, gallbladder, kidney, spleen. The rest are all on the central line. So I believe and think that when saying the related muscles, you're actually looking at something to do with the organ. And now that could be multifaceted of actual organ health or adhesions in the viscera or back to an emotional component, right? So we are these complex systems and we need to understand that we're complex. It's just not that simple. Coming back to fascial connections, then Tom Myers brilliantly, right? Like it's called anatomy trains because he was like train tracks at each little crossing point. They were picking the like most synonymous way to go and continue from toes to head in this uh example here. And so the superficial lines actually end up looking like the yang meridians. And so then I had three yin meridians for the deep front line of fascia. And starting from the foot, there's three muscles, just happens to be that way, um, that start up from the foot. So I started tracing up from the foot, and I have since, and I'm currently doing it in a more in-depth version of breaking down the deep front line of fascia, which contains all of your diaphragms. Um, the iliopsoas is actually part of the spleen. And then Dr. Jerry Tennant, who wrote the book Healing is Voltage, he has one of the best explanations for myofascial meridians, tying them in with the energetic meridians, and that they are absolutely the same one in the same. And that is a muscle is a battery. And as it pumps and as it moves, it creates piezoelectricity. That's energy. And then you string a series of batteries together, and you have a meridian, whether you want to call it a myofascial meridian or an energetic meridian. So the iliopsoas is actually anterior deep front line of fascia, which is the Chinese medicine spleen meridian. So that's not included in this. And then a plug for my other series and a one to come. There's a current one of the muscles movement meridians. The next one's just going to be myofascia meridians, where I get more in depth and see things like on the back line there's this like spot where it skips, and then you look at the actual anatomy and the lymph is not there at that one vertebral segment. It's wild. So yeah, we have ties into both spleen and looking at that battery pack, right? So if you have someone with the iliopsoas thing, um, spleen has a connection to worry, and then kidneys is the fear, and so then we have ties to emotional components. Whew, Asya, anything?
Yeah, I just want to quickly separate for anybody who might have gotten lost on the meridian talk right here. There's two different ways that Jordan has been looking at the relationship between Chinese medicine meridians and myofascial meridians and the relationship to the actual muscles. So AK has a theory proven, they have their own tests and whatever on the muscles related to a specific meridian, and that has less to do with a myofascial relationship and more to do with if that meridian is struggling in any way, then these muscles will also be struggling in some way, probably test weak. But Jordan has been specifically looking at if you were to overlap the actual location of the Chinese medicine meridians and overlay that with a myofascial train, what starts showing up. So that's just something that he's parsing out, not something I've seen done anywhere else before. So really excited for that work, but it's not on this page, spleen, as he was talking about, because it's not the like first thought that comes up when you think about muscles related to Chinese medicine meridians. There's already a thought process on that that has been teased out by Dr. Goodhart. But really quickly on emotion, we'll hopefully go through all the other signs a little bit more quickly than this, but consider the emotion of fear related to the kidney meridian and knowing where the psoas is. Your most vulnerable place on your body is around your lumbar spine, especially anteriorly. So like on the front side, that's where all your squishy, important vital organs are. That's where the body wants to protect itself the most. So, you know, knowing that that area can be exposed, it kind of makes sense that an emotion that can go with that would be fear. So, you know, if you're, that concept can also show up from the perspective of a dog that feels very comfortable and safe with you, is not afraid of you, is probably going to roll on its back, show you its belly, and safely rub me. That's its most vulnerable spot. So just a consideration that's also the same for a human. Just because we're standing on 2 legs instead of on 4 doesn't mean that that's not still one of our most vulnerable areas, you know, except maybe our neck. But starting to understand like why we might be holding certain emotions in certain areas of the body.
That's really interesting that you mentioned that, right? Like the anterior neck. If we look at like scalenes and longus coli, they kind of span that cervicothoracic junction similarly, right? Like they span through here and have a relationship down below. Reactors, kind of interesting.
Mm-hmm.
Thank you for that aha for me.
Mm-hmm.
Aussie, would you be so kind to demo us a little bit of movement? Any PT things to give people? I'm now pinning you and stopping share, so you are live and in front of everyone with your big ass calendar.
Which I have yet to actually fill out completely. Okay, so since we were talking about open and closed chain, obviously we all, hold on, I can fix it. We can do this better.
I don't need to see your face.
What is a face? Okay, so obviously we all talk about hip flexion from the perspective of like, let's do this, but that's open chain concentric movement. And if you immediately flip that on its head and think closed chain eccentric, again, it's not eccentric, it's still closed chain concentric movement. Changing, you know, let's see, instead of insertion going to origin, origin going to insertion, then we have this movement, which, let's be honest, we know that's not really how that works in the world. We're not accelerating ourselves towards the earth. You know, with gravity, we're actually trying to suspend ourselves against gravity as we go towards the earth. So it's not really a concentric closed action for the psoas to bring us forward. Yes, it has to work a little bit, but it's also the job of muscles on the backside to keep us from continuing to fall forward. So this is that concept, and something that I might get into a lot of detail in a future course of like, okay, well, if that's not what the psoas is doing when we're standing here, then what is it doing? It is doing something. It's not doing absolutely nothing because it's still participating in stability of the lumbar spine. So that's where I was saying before of let's have some consciousness around before I go and take this away, right? Normally taking something away involves some kind of release, massage, whatever modality you choose to use, whatever tool you have in your toolbox. But before I go and take that structure away from the body using it, like what's the body going to have in its place? What am I planning on giving back? How is destabilization going to show up potentially? And if you notice that, if they get off your table and they complain of something new pain, feeling wobbly, you know, kind of check in on, hey, was that actually something really, really needed before I further go digging in the guts?
Would you show a like a lunge for us, please, as like a lengthening so people can also see what it would be like to have a psoas belong, please.
So this would be the long side psoas. You could go into a kneeling position, or you could have, you know, just a long step. but a lot of people are looking for, again, a stretch feeling sensation, and they will often try to like tuck under or lean all the way forward. Big thing to consider is whatever you're doing here, you're going to start getting into quad. So as far as cueing is concerned, if you really want them to get the hip flexor component of something, it's a lot more subtle than you think, because as soon as you start going real far, now I'm starting to feel it into quad. This is a lengthened position of the psoas, like in the most literal sense.
And your right leg would be shortened.
Relatively speaking, yes.
Mm-hmm.
Hip flexion, hip extension, long psoas, short psoas.
Oh
But
yeah,
again, from like the carpentry perspective of the body and movement, that's
and then major antagonists there.
hip extensors, glute max, hamstring, primarily. Also hip internal rotators, because psoas is a little bit of an external rotator, being on the lesser trochanter, which is medial side of the femur. So hip internal rotators would be your TFL, also glute max, a little bit of glute med.
Manual stimulation of adrenal glands help relieve pain in the lower back or inner thigh. What is manual stimulation of adrenal glands? Digging, like manual release, like getting down there and to the top of the kidneys?
I don't know that direct stimulation to an organ will result in release of muscle tension.
There is the remember we were talking about neurolymphatic and neurovascular points founded by some of those original AK guys.
Right. But those are other
That,
points. Those are not usually like right on the organ itself. I don't think that organs,
but
I
that
guess, depending on fascial adhesion, like sometimes liver gets pretty stuck and it needs like a liver pump movement kind of thing. But
I have seen pictures of adrenal glands that people have basically lived for years and years in adrenal fatigue, and they grow and they're monstrous, and so that could be a component of, like, that starts pushing on your peritoneum, and then yeah, then you have pain. So we need to carry on.
move
I
on.
think you all
Uh,
feel very well versed in the iliopsoas.
Anybody have any questions while we're moving on?
here, again, a lot of it's for you to understand how this whole manual is put together, and a lot of it's going to be future stuff as well. Pterygoids are just awesome muscles that people love to torture with manual therapy, and I don't think that is necessary at all. But that's the cranial therapist in me speaking. What I find interesting, this image gets a little weird in seeing it, but you have the medial pterygoid down here, and so that's this line. And then you have two heads to the lateral pterygoid, and they create this zigzag between the two of them. And then if you look at, oh, well, in here they call them the external and internal, medial, lateral. If you look up, the functional anatomy of jaw and the jaw motion, pterygoids are pretty much involved in everything. So you can palpate and feel if you go to the medial, I'm sorry, if you go to the angle of the mandible and come inside of the medial bit, you can just feel down in there. And you can get to this internally as well. And then if you go right above your zygomatic arch and push down and in, trying to squish down to the sphenoid, you will feel, ow. Uh,
Don't hurt yourself.
yep, you will feel the um, pterygoidus externus, lateral pterygoid in there. I find, again, if you just gently move the cranial bones, I will take people's, I'll like trigger point their pterygoid, and it'll be like a 7 or 8. Just sit with the cranial bones of like the maxilla, and maybe the mandible, and those can go down to like a 0, a 1, a 2. Really simple by being very gentle. So, two parts on that. That is, don't terrorize the pterygoids because they don't need to be. Um, and then also don't let people terrorize your pterygoids. Um, it's just not necessary. The movements there, yeah, pretty much everything. All jaw movements, they are included. Um, Vasya, anything on this one?
I actually learned the like how nice it is to have more of an indirect release to a muscle, especially around the jaw. Like he was saying, move cranial bones, where these muscles attach, as opposed to getting directly on the muscle to achieve a release of some kind. But intraoral work for release of those muscles, again, not directly on the muscle, but like palate work and manipulating the jaw, from like the perspective of your teeth. Again, very indirect. It actually has really nice results for getting release work to those muscles because you're talking to where they attach. And it's very subtle, and it does take some practice, especially doing internal work in general, but very much on that page of trying not to smash on people's faces.
Unless that's what you like and that's what they like. And then my dad's dad joke comes to mind. The masochist says to the sadist, "Hit me," and the sadist says, "No." Um, so not well depicted here, because it's kind of small. Can have some like cheek pain from this, but the big one that I always think of, no, and find time and time again, personally, last year as well, um, ear pain, ear issues, stuff with the ear.
Mm-hmm.
You can actually do great help by finding some more balance to the pterodactyls.
Yeah, a big part of that is also they attach to the sphenoid. So really, really, really important cranial bone right there. And yes, I also have a few clients that have some chronic ear stuff, whether it's some kind of ringing, tinnitus, however you say that, um, or like a sense of fullness, like their ear wants to pop and it won't. I usually find that that area is involved.
There's also something with back in that zone and like a drainage canal. I think it's just pterygoid. Yeah, I can't remember the technical term, but yeah, the sorry, Dana's laughing that but with the names that we're giving, it sounds like Andy's teaching the class. Um, yeah, there's a drainage canal in there, and it helps when those things are, balanced. Um, so looking at the fascial connections again, this is considered part of the deep front line in Tom Myers. Uh, I found, and I haven't really tested the pterodactyls, so pterygoids. Uh, there's, multiple sources. You can look them up. There's Touch for Health, there's AK, and there's all those offshoots, and you can kind of find your way in through. There are some ways, right? These are non-testable muscles, obviously, like, meet my pressure on the jaw, that's not going to work. Uh, but you can utilize stimulus and TL, TL being therapy localization. So I found that someone put this related to stomach. That kind of makes sense. There's a neurovascular point right here over masseter, but that whole TMJ complex and the jaw and its connection to worry. Um, if I think of the deep front line of fascia breaking it down, spleen kind of comes up and finishes at the base of your tongue and the digastrics, and it's has a correlation I find since we receive nutrients, the yin of energy, right? Instead of it coming through our umbilicus, it comes through our mouth. So the first is spleen, and that opens the mouth. Um, Liver then comes up and is more anterior, so it's the inside of your lips. So this is the latching and suckling. And then kidney is basically the swallowing. So I'm not sure. I will have to delve deeper into that and get back to you all as to what I actually think on that and do some more testing. I believe that I got to this stomach and worry from someone else's information, right? And this is just ways that you overlap and look. And again, none of this is dogma, but it's just things to think and consider and notice what comes up when you're working and listening.
Yeah, something that comes to mind for me thinking about the emotion of worry, a lot of jaw tension, clenching. Um, I mean, consider the amount of stress that's floating around in our world today, and a lot of people get diagnosed with, diagnosed is a strong word, but they're recommended night guards because, they grind their teeth or they probably clench in some way. And so I wonder if dentists would adopt a strategy of, being able to check in on more than just your teeth and all the other things related to the jaw and how the movement of the jaw might affect your teeth. That would be a nice dream of mine for doctors to actually look at the whole body more often. But
Ah,
considering what the jaw can represent in so many ways, not too far off to understand where worry and jaw clenching can kind of go hand in hand. Also, another very well documented relationship is jaw movement to hip movement. So, if we're considering, again, compensations, things to look out for from destabilizing the body, understanding that if there's something going on in the pelvis, Jordan said that he found that somebody said, I'm not as good as remembering who's responsible for what things that Jordan has come across. But if it's in the pelvis, it's everywhere. But then if you find there's something in the pelvis, I definitely recommend taking a look at the jaw. Jordan has actually mapped out very specifically the relationship of points on the jaw to the pelvis. But in general,
if you
if
just remember, I'll just, yeah, maybe you were about to say it, just interject, but basically TMJ, think hip.
yeah,
Yeah.
it's a joint, just like you're not just like, but it has a disc and it moves and can behave, especially from a compression and decompression standpoint, very similar to the hip. So consider that if you're trying to figure out why somebody's not getting resolution in their hips, check the jaw. If they're not getting resolution in their jaw, check their hips and start that balance process. But
As above, so
um,
below.
huh,
As above, so below.
yes, yes, polarity. But just visually consider knowing that at the end of the day, the brain is happiest when the body can, view the horizon horizontally. How nice of them to give us the same word for that. But if the body's, you know, happy place is actually some kind of contortion that would end up like this, then it's going to kind of reverse engineer. Okay, well, how do I find a happy place that basically looks like this,
Hold
but
on.
still keeping the horizon? And so now you get compensations, from that standpoint. And again, deciding who's on first and who's on second. I'm sorry, who's on first and what's on second. Deciding like who's important or who's driving it, that's its own, down the rabbit hole. But places to start looking for relationships and being like, I don't really know why I can't make this resolution happen that I know can happen. Jaw and hip. It's really easy for the jaw to shift to literally compensate for a position that the hip doesn't want to go to.
Would you show us your jaw?
My lovely jaw issues. Okay. Again,
I'm super curious to see today after knowing a little bit of what's going on. So
okay.
basically watch her medial incisors on the top and the bottom, and she's gonna open and close very slowly for us. Right? So she got some whoa and whoa, right? You see that tracking? And
Really
so there's some
not
cranial
painful.
balancing that when I see you next, we're gonna get in there. Would you show the lateralization movement of the jaw and then the rotational cog? Yep, so that's lateralization. It's a really nice way. If you hold that temple spot or pterygoid, feel them kind of kick in. And then a way to accentuate it, right? So if she rotates her head one way or the other,
Ooh, really quick. So
yeah,
pterygoids do contralateral deviation. So
yeah,
right side
right,
pterygoids will deviate your jaw to the left side pterygoids will deviate your jaw to the right. So
yeah,
if
thank you.
you're trying to feel what should be popping out when, it's a lot easier to feel lateral pterygoids, or it's called external because it's more on the outside, and medial or internals because it's more on the inside. So if you're shifting your jaw to the left, I feel this side pop out a little bit, and a little bit under here, it's just a little bit more subtle than that. So cogs.
Yeah, just the rotation with the lateral deviation.
Oh, okay. So then you can.
So when she rotates to the right like that, her left TMJ opens and then she can do lateral deviation both ways. See how that feels, compare, and then the other way as well. This is a homework that I will give. Oh, something else that I thought about was I have seen pterygoid issues for people that have undergone long dental surgeries and their mouth basically gets stuck open. And then after all of that, probably being drugged and, like similar to like falling asleep on the couch with your neck in a weird position and you wake up and you're like, ouch. Same thing with being in a dentist chair with your mouth stuck open and having, local anesthesia or whatever.
Hmm.
Uh, or, I had general for having my what do they call it? Wisdom teeth removed. So yeah, you can see pterygoid issues with that.
Just for feedback for anybody who wants to know what dysfunction might look or feel like on their clients. So I have a decompressed left TMJ and a compressed right TMJ, and looking to the left and then doing my cog, it's very difficult for me to close my left TMJ. It's very difficult for me to deviate to the left because it's stuck open. It doesn't really want to close. And so if I'm going that way, then I'm opening the right, and the right's like, great, that's fine. But my left's like, no, thank you. So I really feel difficulty deviating to my left when I'm looking left.
For fun and gets and shiggles, how would you do then a full body integration of that? How could you help yourself with a full body thing instead of like we're just doing a localized thing here, right, with your neck? What could you do for your full body?
Well, without understanding anything about whatever the rest of the body is doing. My first, I would use this almost like a litmus test, an assessment, and then homework, assuming that I made the corrections that I wanted to make. But the movements of the spinal segments are all opposite, right? So if I turn at the cervical spine to the right, then relatively speaking, thoracic spine will turn right. Relatively speaking, lumbar spine will turn, sorry, let me say all that correctly. Cervical to the right, thoracic to the left, lumbar to the right, lumbopelvic to the left. And so being
Stand
able
back
to
and kill us.
check, nah. Mostly all of me, kind
No,
of, some, but I'm so
well,
bad.
this time we need to see your face because we're talking about it.
Well, thanks. Okay, so I would want to check to see if somebody is capable of finding the relative changes in like these segments. So cervical to the right, in order for me to counterbalance, thoracic needs to go right, lumbar goes to the left. So lumbar and lumbopelvic are two different things. So thoracic goes to the left, lumbar goes to the right, lumbopelvic goes to the left. And then ideally you would have a supination and a pronation, supination in your left foot and pronation in your right foot.
And so you could split stance that to accentuate it as well.
If you really wanted to.
Yep. Cool. Thank you.
So it would be like this. No, it would be like this. If I started it here.
And the thing is that you can play with both of those directions.
Right.
Because you should be able to do it all, but you want to see where there's resistance and you can go, if it won't go right, go left and then try it back again.
The reason why that's something that I would do in real time every single time with my clients, as opposed to, well, this is how the body is supposed to move, is because the body is supposed to be able to do all the things. And so the discernment for you as a practitioner, hopefully, hope maybe all of you on here are practitioners. If not, slightly disregard this, but the discernment that you have as a practitioner of understanding what it is the body needs in that moment is like the reason people are going to you, right? So it might be that somebody needs to learn how to, instead of dissociate two segments, to associate them, because that's not something that they're capable of doing in that moment. And it has value too. It's not just, well, the body only ever functions like this. It's like, oh, there could be a reason and a time and a place for them to need to operate there. And we don't want to program into the body a single way of operating. We want to program the ability to handle adversity and changes, because sure, there's a gait pattern, which is kind of like your baseline. This is what the body should be able to do at minimum and well. But the beauty about the human body and the way it's created is that gait allows for all the other things to happen as well. And so I tell this to a lot of my sport specific people, especially dancers who like to stand with their feet turned out. I'm like, it's fine that you live there. It just can't be the only place that you live. You still also have to live with feet pointing forward. And if you wanted to, you should be able to turn your toes in and exist there happily in that moment. Maybe not for an 8-hour workday, because it's not healthy for your particular body and what it needs to do. But a healthy body shouldn't immediately complain as soon as you ask it to do something that's not normal. So it begs the question, what is normal?
Yes. You made me think of one of my favorites is people learn knee over second toe in yoga and then never allow themselves to experience anything else. And then they step on an edge of a sidewalk and they stumble, fall down because their body locked in and part of it's belief and part of it's training and where they're capable of being, but they locked in. Whoa, that's not what I want to do at all. They locked in knee over second toe, and so they weren't able to have that experience of having the reflexes of their foot go, oh, hey, whoa, and snap back, and they fell. Yeah, it's funny the little things that we learn from some people, and I even remember my own father using something I said against me, and I was like, no, that's not what I meant.
Right. I think that's something that I'd like to get into very in depth. The whole like it's an okay place to start. You can't stay there.
Yeah, that's good. I like that. Okay, we're gonna push on. Hour in, two muscles, but a lot of information, and hopefully, you start being able to utilize this manual and think differently and start seeing things. We're gonna go to the lovingly known as upper cluster fluster, number one muscle there, pectoralis minor. It's called an upper cluster fluster because
Well, I just want to point out that we already went to the lower cluster fluster. That was the
all right.
psoas. Yes. Pec minor, also the muscle that everybody thinks is to blame for everything.
It isn't.
Everything. Um, a little bit more than psoas. I will admit that I do get into a pec minor more often than I get into a psoas. But a lot of people, again, visually, if you are rounded shoulders, everybody is automatically assuming it's because something is pulling them into it and keeping them there, as opposed to maybe something not participating very well to keep you out of it. But pec minor is, I don't know, probably one of the most important muscles that I check on everybody for every reason. Doesn't matter what they're complaining about. I always check pec minor.
It is a potential impingement of the brachial plexus. Uh, The other trouble thing that I see there, if you look over here, we have the under movements, the arrows, it elevates the ribs. It is a big time shoulder mover, right, as it attaches to the scapula, but it can be utilized for breath and breathing. So it's an accessory breather, but in your day-to-day, Asya, do you want to be breathing with your pec minor?
No, no. Accessory muscles to breathing are like I'm running away from the lion that's trying to kill me. Kind of should be used in those situations, which hopefully none of
You
us are
know,
in.
I mean, up here in the Santa Cruz Mountains, we have cougars,
Hey,
so.
hey, hey, South Florida, we got gators and Florida man. I'm gonna just say that I win that one.
So it's the third, fourth, and fifth rib. So then, if you pair that in with scalenes and you have scalenes on the first and second rib, and then pec minor, third, fourth, and fifth, there you go. You don't need to use any of your other real breathing muscles, and you can just breathe with those. That pulls everything up, and then your brachial plexus is like, fuck. And then you get, carpal tunnel, nerve pain, numbness. I mean, it goes on and on and on.
Yeah, the relative issues that I see people have with that are actually brachial plexus. I mean, there's so much at play in the shoulder. Oh, speaking of shoulder and speaking of not quite pec minor, more serratus, I think we're gonna get to that later. Recently had a guy who came to me with acute back pain and it ended up finally being a shoulder thing. And breathing that resulted in a locked up and tight low back and acute pain.
That's a
So also, like I said, I check things in the shoulder, especially ones that attach to the torso and the shoulder for almost everybody.
I just noticed it's interesting here. Werner has one, two, three, four ribs with pec minor. I always thought it was three, but I'm sure there might be some fibers and some stuff that do different things. One thing that I haven't pointed out so far is that you'll notice a lot of muscles, what the yellow lines are showing why it says shape and fibers are triangular. There's an importance to that, as well as another fascination and fixation of
That's
Jordan liking triangles.
that Jordan loves triangles.
It's
It's
true.
okay, Jordan. It's better than being a square.
Definitely. If I'm triangular, I can exist in compression and in tension. So, here we go. When we come down here, pain referral. So here it is all the way down the arms. Again, that brachial plexus, if it gets shut off and cut off from vascular supply for long enough, yeah, your entire arms can complain. Uh, this is one of the muscles that I disagree with in terms of what it's related to. In
Meridian?
AK.
Yeah.
Yeah, in the meridian. Actually, also, if you, while I blabber on for a moment here, if you could look up and confirm that and see in Touch for Health what pec minor is related to. Maybe I'm wrong, but there's a couple like anterior deltoid, but basically anything around the coracoid process I found relates to lungs, right? And this is my studies of taking a magnet and putting it over. So the alarm point for lung is right next to the coracoid process. Lung 2 is slightly superior. Lung 1 is slightly inferior to the coracoid and medial to the coracoid. So it's like, we look up here, it's kind of right in here and here, or here and here, goes 1, 2. Um, and I find that it would respond pec minor to you know, whatever the pole of the magnet was on lung, um, which I like because it has the sinew and the pain referral pattern and even the fascial connection. So the deep front arm line running from your thumb, which then correlates here. This is the sinew. This is from a manual of acupuncture. Right there, sinews where they're myofascial lines, and they're kind of similar and crisscross referencing, but this one definitely is just beautiful. Like the referral pain, the sinew, the fascial connection, they all kind of add up.
You're gonna
I
love this. Touch for Health doesn't actually talk about pec minor, only pec major.
oh, huh.
Huh.
Anyhow, yeah,
Well,
anything you having to add in there?
Um, I often find that things that look like a pec minor problem, like I currently working on a guy that has a complaint of shoulder issues. This is wild. It's specifically left shoulder, like debilitating pain from pitching. This is a weekend warrior guy to the T, not a guy that pitches, but goes and does like softball, with his company, pitched for like 2 weeks in a row. Right arm feels fine. The left arm is like, I don't know, literally like makes him want to cry. It's all jaw, all of it. And every time that I see him and it starts to get better, his right side whole pec area is like super rolled forward. I never touch it. It never actually needs work. The closest that I get to it needing work is actually his upper trap. Otherwise, it's all his right side jaw. And then his whole pec area relaxes beautifully. Don't actually have to touch the area. Again, not that that's always going to be a relationship. That's always going to be the case. He has a long jaw history. You think my jaw looks crazy and clicks all funny. His is like, you can hear his jaw click in the other room. Like, it's wild. So just consider there's a lot, let's go to the emotion side. What's the emotion there, Jordan?
Grief.
Oh, okay. Okay, fine. Let's curl up in a ball and cry. Like literally, it's like everything comes forward and closed and you want to protect yourself. And the relationship between all of this coming forward, that now changes your clavicle, things that attach to the clavicle. It's a whole host of neck and jaw stuff. So if you're seeing a shoulder thing, check jaw and neck, just see what's going on and minimum palpate it if you're capable of touching. If not, ask a bunch of questions. Hey, you've been having neck pain, headaches, jaw tension, you have dental work recently. Just start checking to see if there's something there going on. Otherwise, my next reason to look at the shoulder is if somebody says they have elbow pain, because elbow's not interesting enough to actually have a problem until it has a problem. So that's a different story for a different day. But shoulder, if it looks like there's a shoulder problem, there probably is a shoulder problem, but that doesn't mean it's being driven by the shoulder. So just go and ask the question kind of in the vicinity. And then, of course, Jordan actually taught me this jaw tension and neck tension and pec tension on one side.
Hmm.
Go check the hips, both sides.
Wait, I'll clarify on that. Um, so as Asia was saying that there's that she said maybe sometimes the upper trap, my immediate thought is the cranial accessory nerve runs to upper trap and SCM. And I have found a pattern time and time again that if I have someone with, neck or TMJ dysfunction complaint, this spans back to teaching trigger point way, way back in my career. And students were wailing on an upper trap and they're like, it's not, it's not dissipating. And I'm like, well, stop. Like, stop forcing the body to do something it doesn't want to do. And we palpate a little bit, and same side SCM and upper trap were both hypertonic. And then having a cranial background, I was like, oh, and I was like, let's check the jaw. And I was like, holy crap, the jaw. So then we trigger pointed the jaw. I went back in the SCM and upper trap melted. So again, hypertonic meaning just to palpation, like if you squeeze it like a pincer palpation to the SCM or the upper trap, and you have unilateral hypertonicity, right? So it's like a 7 here and here on my right side and a 2 on my left side. Think jaw. But before you go chasing the jaw, check below the clavicular line to pec minor as an indicator and see if that's similar. So if you then have SEM, upper trap, and pec minor all at 7s on one side, think of the pec minors pointing down that you need to go deal with um what's that, Claire? I missed that. Write it in the the Zoom chat for me, please. Um, so if you have pec minor, SCM, upper trap, all unilateral one side, think of pec minor as pointing down that you have to deal with the pelvis. And a lot of times that's an SI, sacroiliac joint dysfunction. And even further than that, sometimes the ankle and have
Mm-hmm.
an ankle issue. So I will have people come in and they have TMJ dysfunction complaint, and I'll begin, history, blah, 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 palpate, check that. Oh, pec minor. Go down to the pelvis and see what's off there. A lot of times piriformis is off on one side and locked on the other. If you know AK, that's a pelvic category 1. AK is applied kinesiology. And then I will go down and like compress the feet and see if I can change the pelvis. And so sometimes I will treat a foot and a pelvis and then go back to the TMJ and it's like 80% better. And they're just like, what just happened?
Like, can you imagine, like, you have a foot problem and you're walking on it all day and your body's like, every step you take is like, okay.
Or just even think of yeah, you don't shift and load, so you never get the lengthening of one side, and so one side's always short and tight. Oh, thank you, Claire. Cool. Uh Pec minor to stomach meridian.
Yeah, I was just saying I looked in AK in my big AK book and it doesn't mention pec minor for related meridian, but that's awesome. Thank you, Claire.
Um let's see if I can do that so everyone can see. But she put it in the chat, but there you go. Yeah, again, right? Like, go find your own way to test. Like, none of these people that come up with these things tell me how they figured out what they have. So I have given you a way. Go get a magnet, go muscle test, see what you feel. Fine. Let me know. I would love to hear. Great pec minor. That was a good squirrel, actually. It is a good indicator. Thank you for reminding me about that. Asi, would you really quickly show us some pec
My
minor?
really awesome rolled shoulders that I naturally
How would you
been working on for you guys for
how
30
would you
something?
give some physical therapy of somebody to go home with something um
Oh
and
man.
they integrate it through their full body so that it's not just a I
See,
actually I have
when
them. I
you
have a
say
small space.
words like physical therapy, then I go back to my PT days. And I remember that I would have probably wailed on someone's pec minor for like 20 minutes, which I would never do in a million years now. Um, can I see me, please?
Aren't
Did
you?
everybody? No, I'm looking at your screen.
I pinned you. Did I pin myself?
Am I looking at? Oh no, wait, hold on. This is me. It's my fault. I'm doing things.
Pinned.
My bad. Sorry, guys. Technology. Yeah. So PT days would have me like have them on a table, literally getting in here and like releasing that,
As
which
it
is
that
great if it needs to be released. So check in with yourself. Does it actually need to be released? As far as like full body integration, right? So like very, very opposite direction that the pec minor goes in. It's very much a like roll shoulder forward and down and across. So if you want to actually release it literally, that's a great way. Again, only if it needs it.
yeah, it does get kind of needing a little bit of that tissue work in my opinion. It gets what I call adhered, right? Because one of the things that you noticed Stasia did was put her hand above her head, and this is a movement that we've pretty much eliminated from modern living, right? All the dexterity of the shoulder has practically been removed, and then that person needs to get something out of the back seat, and then they're like, ow, right?
Right.
So big motions of the shoulder meant for climbing and swinging or whatever, and it's been eliminated in our modern living.
Everybody should go climb. Shameless plug as a climber.
Would
Please
you
go.
just show like the pec minor stretch there with like how could you integrate that into a split stance, please?
I don't even know where that is right now.
That's fine.
Okay. If I have a left leg forward, I would probably be wanting to stretch left pec because again, thinking gait patterns, opposite arm, opposite leg. This is what's going forward. This arm would be stretching. Again, not to box you into, well, this is how it has to be because that, you can definitely open the other way too. But if you have one leg forward, you could consider what else it is you want to be feeling down here, but you could prioritize a pec stretch first all through here, or even anchor on a door frame.
Mm-hmm.
Bent elbow, straight elbow. I don't have a huge preference, but definitely consider fiber orientation. It's not a super horizontal muscle, so I would probably prioritize a bit more of an angle at the arm if I'm trying to actually find pec minor. Everybody's a little bit different.
And then plugging my arms, my fascial movement meridian course. We then do the movements and motions through the fingertips in both opening and closing, right? To learn to pump the muscle. So in this case, it would be thumb to her coracoid to close it, and then feeling and finding thumb away from coracoid as much as possible. And yeah, beautiful. Thank you.
Yeah, one more thing on
Oh,
that is
yeah, keep talking.
considering that the body, of course, has the things it's supposed to do, heavy quotes, but if you reverse gait, keep left leg forward and actually rotate torso to the right, and then also want to ask for a pec stretch, it's not that you can't get a pec stretch, you're just getting a pec stretch in relation to a different set of muscles that you are now contracting or closing down versus opening up. And so that might actually be what somebody needs relative to what you find as relationships that need rebalancing.
Thank you.
Yeah.
We're gonna go down to the hand. Shoulder stuff can be grip stuff. Grip stuff can be shoulder stuff.
Oh man, this is my favorite thing to talk about with my climber friends. I get all the time. How can I get my grip stronger? How can I get my grip stronger? Use your shoulders.
Use your shoulders.
Yeah, actually use your shoulders properly.
So, we have the opponents of the thumb, pollicis, and then opponents digiti minimi of the uh your mini-me, your pinky. Um, the ability to do this is also one of my favorite. The pinky to thumb test is one of my favorite tests to keep it as an indicator. Um, it's important that ability to close the hand also, and an important is the ability to open the hand. A lot of the people are getting contractures in their hands, right? And this is their resting position. And they don't do anything to open their hand, to open their shoulder, to open their chest and stuff like that. And so this is really important for grip in terms of intrinsic muscles, closing the fist, grabbing, bringing food to your face. Asia, what do you got?
I have crazy hands.
Yes, you do. Those things can't open. That's ridiculous.
Um, so grip is a really fun thing for me to check. Something that I've gotten from immaculate dissection is checking grip from above and from below. So this starts to indicate different areas of compression, basically brachio. Oh my god, it's a word.
You were starting to say brachioradialis,
I know it's not what I meant. No,
coracoid,
no, the nerves. Oh my god, brachial plexus.
brachioplex. Oh, it was too easy.
Something that has a break in it. The brachial plexus, being the thing that supplies the entire arm, if it starts to get compressed in certain areas, you can start losing grip in various planes or in various positions of the arm. So I always like to check grip above and below, not necessarily because I'm thinking that I have to go and work on stuff here if that's not their primary complaint, but it it just gives me some more information about like, okay, well, where's the body struggling? If I know there's some struggle here, that might start informing me more about what their actual complaint is. Like maybe they were talking about elbow pain, or maybe they do have some kind of neck pain. But yes, grip is. Oh, I can actually talk more PT specific about grip. There's a relationship with mortality and grip. There's been a ton of
Yeah.
studies done, and I find this absolutely hilarious for so many reasons, but primarily because if grip is so related to mortality, and if people who are at risk for dying sooner than later, usually from some orthopedic reason like falling as opposed to like organ failure, um, they literally spend their lives gripping their walkers and their canes. And somehow that registers as a safe way to exist when we also know the importance that grip has in terms of your ability to, manage your lifespan.
Yeah, so what do you think that the connection is? I heard Dr. Peter Tia briefly speak on that. And he now has people dead hang um and work up to being able to dead hang for 2 minutes.
Yeah, that's something that, again, I have learned that more indirectly just as a climber. A lot of things have improved without me trying or thinking about them specifically, just from spending time being on a climbing wall. But I think psychologically, there seems to be more control with something that you can hold on to, right? People will opt to hold on to walls and furniture and countertops, and use the smallest muscles that the body has to offer, basically, for their safety, because it's a purely psychological thing. Because I think there's more of a control component. It's something that they can hold on to. It's, they can see it. Whereas there's this complete lack of consideration for the largest muscles in the body that should be capable of doing the work of standing and walking, which is, primarily glutes, hams, quads. And it's just, not a consideration. But people will feel safe from a psychological perspective if they have their walker or their cane to hold on to, even if they're like dragging their feet and entirely holding themselves up by their arms. And yet their grip strength will test like awful.
Yeah.
So yeah, I think it's a very much psychological thing.
So if we look at then the related meridian, right? So if we were to test the opponents, I believe I found this one true. In fact, pretty much any muscles that would bring food to your face. So your grip, your flexors, your bicep, um, pec major clavicular, and neck flexors, right? So this whole motion of bringing food to your face is all governed by stomach. And that one kind of makes sense to me. I'm like, oh yeah, I get that, right? Like, and then antagonistically, spleen governs the removal. So triceps and lats and stuff like that. So there you have worry as being a big one. And then that superficial front line of fascia. But also what's interesting here, and a little self five to myself, I've never seen anyone else ever do spiral lines of the arm. And so we're looking at grip, it's pinky and thumb, and that creates a spiral line of connection, as you see here on the image, the orange and the blue. And the thumb will go back and have a connection to your lat, and the pinky to your pecs. Lats and pecs connect deep to your core. And so if you have a strengthening um, of the grip, or strength in general to the grip, then that seems that you would accentuate core strength as well. Um, I vaguely remember Dr. Peter Tia saying with the grip strength, they were briefly theorizing on it. And I still haven't really heard a good one other than that the research does actually seem to show that, stronger grip, uh, better lifespan mortality, right?
Yeah.
The body encyclopedia cognitive grasp. So there's a mental component, right? Like of your
Literal
opinion,
grasp.
little grasp on reality, physical grasp. I mean, that's just wild, right? I love merging those two things. And then if we look at um those two lines of fascia, the thumb being lung and the deep front line, and so we have a lung connection as well. So breath and breathing. And then the pinky is
Huh. I just thought about a baby sucking their thumb.
oh,
Um,
and then on the pinky has two, it's small intestine and heart. Um, so we could look at the heart connections, and again, that's breath and breathing, vascular health, getting blood flow out to your extremities. I mean, there's just so many connections here of just looking at two little muscles. I love it. It's just really beautiful. Um, oh, I had one last thing, but Dr. Peter Attia was talking about, you were talking about like grasping onto walkers and stuff like that, and that might be a safety thing, but he was talking about that either or if you do slip and fall, the grip and having grip strength, you're able to catch yourself, or you're able to brace yourself in a way that you're not falling down and breaking a hip like a classic elderly person. But
yeah,
just
I find most of that ironic. Okay, so let's remember where I live, which is basically heaven's waiting room, as it's been so termed, which is actually more Delray Beach. But anyway, that was my early career, geriatrics. And the number of people who would come in saying, I want to be able to walk better and maybe move away from using my cane or my walker. And the very much psychological reliance on this piece of equipment was just mind blowing to me. To then also know the research on grip. Yeah. So when I was saying that the whole like grip and mortality and then people holding onto walkers, I meant that very much from an ironic standpoint. I do understand the whole ability to it's the geriatric version of a pacifier. Yes, it is. Your ability to catch yourself grip wise, but then that for me that begs the question of again knowing how I've seen aging populations, maybe not evolutionarily speaking in aging populations. None of these people are going to catch themselves because even if they have the grip for it, they don't have the strength anywhere else for it.
And then back to our shoulder and grip thing in my kettlebell training days. I remember the whole packing your shoulder, making sure that your shoulder's on, and then pairing that because you're gripping and holding that kettlebell and that weight. And so the grip's on the shoulders on, and then you turn on your core from the top down versus the kind of core out to the extremity. So you get that reverse of, polarity of engaging your core, but doing it through an extremity. And you think about our arms, um, in gait when we're just walking, they're just kind of right, just from the sling. There's not much engagement of the arms until one's actually running that we're pumping. So you think about someone aging, they're not running anymore, so they're not engaging their arms much other than to, touch their phones and put food in their face and drink their martinis at 5. Um, yeah, I mean, any grip. I don't know, do with my hands. Any grip things to suggest? I mean, my big thing that I teach people is to actually learn to open their hands. And when I teach body workers, is why I like to teach people to hold the hub underneath. One of the big things in the AP courses is taking from myofascial and cranial holds of like hold the body. Now you get a compression on your hand and an opening, right? And
Oh, there's your therapy as a therapist.
yeah, it
I
should.
guess I never really thought much about hands. I grew up playing piano, so big hands is just the thing for me. Like span all the keys, as many keys as possible. But it is, you're right. From a what do we do these days, right? We're on a keyboard and a mouse and a phone. And the number of people that come to me saying things like, "Oh, my thumb hurts," and I'm like, "Well, what do you do all day?" It's like I type and text, and I often find that the thumb is it's stuff that's in the hand unless there's been something direct to the hand. It's somewhere up the chain. Recently, it was one of my online clients' thumb issues. Can't hold a dumbbell without feeling it in her thumb, and it ended up being tricep stuff. So that's some arm spiral line antagonist stuff going on. Um, so yeah, consider generally pain complaint, find relationships, also look at the thing because people like when you look at the thing that hurts.
It's true, right? Knock that belief out of the way right away.
Although I will not lie, I had a client right before this, and she's been with me long enough that she comes in, she's like, "Well, my back hurts, but it could be my clavicle." She knows that I go look at everything.
Okay. FHL, flexor hallucis longus. So we're gonna go down to the foot now since we did the hand. Uh, what a muscle. Extrinsic foot muscle, meaning that the belly of it is back here. What do they call that? Posterior calf compartment.
Mm.
Um, and then you got this long tendon that goes all the way to your big toe. And it helps plantar flex toe and foot. Uh, I find this muscle is struggling in our daily living. Let's see it again from the posterior aspect there. Oh, is it bipinnate? Sure draws it there. I'll have to double check on that. Um,
What
this,
muscle fibers?
what's that?
Is that what you're asking? Muscle fibers?
Yeah,
I believe so. I can also reconfirm.
yeah. Sure, while I go on here for a moment, it is rare for people to get onto surfaces these days where their big toe needs to drop down, where their big toe plantar flexes below the ball of the foot or the heel, because we exist on perfect flat surfaces. Um, and that
Oh, wait, sorry. I have a bone to pick with shoes. Because we're no longer on flat surfaces because all modern shoes, unless you're also in the camp of minimalists and barefoot shoes, all shoes have a toe kick.
oh,
So you're even less on a flat surface in the average shoe. Take a look at any shoe from a side view and it goes, whoop.
and so if we look at the mechanics of the foot and it has a windlass mechanism, um what I see when I'm really prescribe people, like, you need to go get barefoot, or I'll give them, like, you got a stair edge or the sill of their door and start practicing, because as the big toe plantar flexes, then the metatarsal will dorsiflex, right? So this joint here goes up and the toe goes down, and then that allows up here with the cuneiforms to actually drop down. And so what I will find on people that are having issues, and it could be up chain, down chain, or local, there will be a pronounced bony protrusion um, right here on the top of the foot, and you can compare from one side to the other, and that thing's getting stuck because they never have that opposition in the foot, and they never get that big toe dropping below. And right, this windlass mechanism is what allows us with these tiny toes and big upright bipedal structures to calf raise, to get off our heels, to push off our big toe, right? And so this muscle has been talked about of being really important of initiating your back chain, and initiating glute max and having a connection there. Um, yeah. Asia?
I live in South Florida, where it is the land of the flip flop. And I
Oh,
remember way back in the day, I couldn't fire glute max for the life of me because FHL was on some other planet doing all sorts of work trying to keep my flip flops on my feet. That was fun times. Yes, I still wear flip flops. But yeah, so
flops.
toes, toe function, the ability for toe function to affect the rest of the body is like a little bit crazy. If you haven't considered it yet, start considering it.
See where I put it, way down over here. Pain patterns, basically big toe pain. But you can not have big toe pain. You can have some sort of hip pain or knee pain because this thing's just not doing what it was, quote unquote, designed to do.
Right. A referral pattern of pain is